All right, so you're joining us, Frostbite Multi-Center Study Year 2, and the Redcap is set up in different surveys, and we made a guide that corresponds to each one of these surveys. So survey 1, looking over the inclusion-exclusion criteria. When you're going through the Redcap and if things aren't crystal clear, we ask that you take a look at this expanded protocol. We've copied and pasted each question from the survey in here, and then we have some more information on what we're looking for. And if it's not clear, we have a Frostbite Gmail account that we all share and monitor together, and you can always reach out to us directly as well.
Oh, nice. I'm sorry, how did you find this? Where do we find that expanded protocol?
I will send it to you.
Oh, okay.
Let's see. So with the inclusion-exclusion criteria, the overall application of this project is to evaluate the treatment on severe frostbite injury. So the patients need to be 18 to 59 years old. They need photographic images of the impacted limbs within 24 hours of admission. They need a diagnosis of post-rewarming severe frostbite with a perfusion deficit. And things that you can use for documentation in the patient's chart to show the deficit are formal perfusion imaging and conducted within 48 hours of rewarming, or a clinical assessment documenting grade 3 or 4 frostbite by the scale below. They also need to be admitted to your center within 24 hours of injury. If thrombolytics were initiated at a transfer center, the window for admission is larger. They can be at the transfer center within 24 hours of injury and receive thrombolytics and then sent to you within 48 hours of injury. If the patient does have thrombolytics, it must be started within 24 hours of rewarming. Your PI or burn surgeons must be able to assess the level of planned amputation at discharge. There will be a worksheet to fill out. I'll show you in a bit. Additional criteria for transfer patients where thrombolytics are initiated. The documentation of the type and approximate timing of rewarming. And transfer patients must have pre-thrombolytic photographs or perfusion imaging. Exclusion criteria: if no perfusion deficit is documented, or it's a grade 1 or 2 based on the visual scale below, they do not qualify. If they are being admitted for a sequela of frostbite injury, they don't qualify. If there's no clinical examination or imaging prior to delivery of thrombolytics, they don't qualify. If there's not enough information in their chart to determine what level of amputation you can expect later on, then they do not qualify. Repeated freeze-thaw cycles, they usually can't have an intervention. They're coming in for wound care, so they don't qualify. And patients without an intervention of interest. So the overarching guide for enrollment, the priority is we want to look at how well treatments work on severe frostbite. So we want to take a deep dive into thrombolytics, iloprost, or rapid rewarming. If they have all three, that'd be really cool. If they have none, then they must at least have good pictures and perfusion imaging. Any questions so far?
When do we have to make the assessment surgically for amputation? Does it have to be before discharge or can it be later?
It doesn't need to be at any particular time point. Just by the time your researchers start entering data, that's when you guys would have a discussion on what to expect with this patient. Typically, it's not known until the end of their admission.
Yeah.
Yeah, so usually what we do, at least on our notes, we document if there's a amputation is planned or not, and that's in the discharge summary. which is helpful. And usually, but we, have at least a pretty good idea of where at least the planned amputation is going to be done at the time of discharge. The rationale behind using that kind of planned amputation level at discharge is because there's a lot of confounding factors with frostbite patients. They might get repeat injury. They might have poor wound cares with infections. And so the military really wanted at least as clean as possible version for the outcomes.
Okay, so
And
really should be at the time of discharge.
yeah,
not-
at the time of
not
discharge,
after.
just
Okay.
where you're planned. And if you can, if you didn't personally see the patient, but one of your colleagues did, you can just ask them. It's just like, hey, where do you think the amputation is going to be? And actually, it's generally people are really pretty good at identifying that level. In general, as long as there's not, infection or repeat injury that happens afterwards. So that's the main outcome measure. We will do some follow-ups. Specific patients will get 6-month follow-ups, and we pay for that separately.
And then if we end up amputating differently than planned, is there
Yeah,
any?
that'll be caught then. Mm-hmm.
Okay.
Yeah.
Okay.
So then going through questions copied and pasted from the surveys. So enter the patient's age. Do they have severe frostbite, perfusion deficit? This evaluation should be after the patient is warmed. It's difficult to evaluate cold extremities. If post-rewarming perfusion imaging is available, the results must mention a perfusion deficit. If the patient did not have post-rewarming perfusion imaging, only grade 3 and 4 injury based on the visual scale are allowed in the study. Patients must have at least a detailed clinical exam and photographs within 24 hours of admission. Select all the methods used to evaluate perfusion after rewarming of the frostbite injury. If patients are transferred from another center where thrombolytics were administered, additional criteria will be addressed down below in question 6. So with the photographs, verify that the patient has detailed clinical exam and photos taken of the frostbite injury, and the photos should be captured within 24 hours of admission. If pre and post thrombolytic photographs are taken, de-identified versions of both will be requested in a later form. The patient should be admitted to you within 24 hours of frostbite injury. Sometimes the exact timing of frostbite isn't very clear, but if your PI thinks it's reasonable that they were admitted to your center within 24 hours of the injury, please include them.
So that's the injury, not the rewarming, right? Okay.
Correct. Yep.
So if someone's like out all night, then they come in, like they're homeless and they're out all night long. When would you say the injury is when they come in the ED in the morning?
I would say it stops at the point where they start to warm up.
Because
So
usually a lot of studies are rewarming,
yep.
but this is
Yep.
different.
So we're trying to limit it to those that have the chance of getting some type of one of the interventions that we're looking at. And so that's why we've narrowed that scope so much. So far, we have not had an issue with enrollment. Because we're wanting to look at one of the targeted interventions, that's why it's relatively narrow. Because most people won't treat. I don't know, do you guys get a lot of transfer patients that have gotten thrombolytics at outside centers?
No, not a lot.
Oh, so then this won't matter as much.
Okay.
So if you have a transfer patient, that was treated with thrombolytics in an outside center, then you have 48 hours from the time of injury. So that's the 48 hours. If they come directly to you, we just want them admitted within the 24-hour window. That way that they're eligible for thrombolytics mostly. If they qualify. Do you guys have iloprost?
Yes, we do.
Oh.
We haven't used it yet because we just got it.
Okay.
Oh, awesome.
We don't have it yet.
Oh, okay. Well, we're supposed to have it. I hope
We're
they say
trying.
we have it.
Yeah,
But
we're
how do
trying.
you determine the onset of injury for somebody who's like homeless and out all night?
It's it's best guess, and we know that
Yes.
there's not a set. And when you go to the data portion, the data gathering portion, we give ranges of when the best estimate is, because I've published on this for many years doing this prospective observational, and that the accuracy of that is practically zero. So
Okay.
we know it's
Yeah.
not going to be super accurate. So it's just your best guess. If if your center says they're eligible for one of the interventions, you do like rapid rewarming, you do some imaging, you do thrombolytics or iloprost, then yes, we'd want them included in the study, even if they might have been a little bit more on the timing might have been off a bit. But if your guys' center treats them and in one of those measures, then we'd want to include them. And if you ever have a question about that, you can always just flag it and put a note in Redcap, and then we can review it too.
Thanks.
Or reach out directly. But yeah, I'll see the
Yeah.
notes in Redcap too as you're moving along. So the rare chance that you do have a transfer patient, they need to have their thrombolytics initiated within 24 hours at the transferring center and sent to you within 48 hours of injury. And to verify that your transfer patient qualifies, if you select that above, question 6 will pop up. Patients who initiated thrombolytics at a transferring center must have photographic images of their injury. And then some centers do not use pre-thrombolytic perfusion assessment formal imaging. And that's okay. This is one aim of the study, but not a requirement. Question 7 will come up for everyone. Verify the timing of initiation of thrombolytics. If your PI believes that the patient was treated with thrombolytics within 24 hours of rewarming, please include them. A detailed documentation of the precise level of amputation. And like we said, this will probably be known by discharge. And then that's looking at the surgeon worksheet. We don't expect you to have the surgeon worksheet completed as you're screening. So then another question comes up. We just want to make sure that the PI can determine that the surgeons have enough information in the medical chart to fill out that form.
So this generally only comes up when the patients get treated. They might have a little bit of treatment in the burn unit and then they leave AMA. So then you really didn't get enough data to assess what's going to happen. If they then come back, then we can revisit that, because we do have patients occasionally that leave and then come back later the same day. So just let us know.
Oh, I have one quick question. That the imaging, pre-thrombolytic imaging, I didn't see, is the ICG with the spy camera qualify for that?
Yeah, whatever you guys
Okay.
use, and we do
That's
that.
what we usually
use
use.
that too. Yep,
Because that's so quick.
Yeah.
It
it
seems-
is. Yeah,
I always think the timing is so important.
yeah.
So exclusion criteria were freeze thaw cycles suspected. If yes, that your patient doesn't qualify. And if your patient was admitted for a sequela of frostbite injury, they do not qualify. And the final questions, number 12, we want to make sure that you're enrolling patients that have an intervention of interest. So we need patients with thrombolytics and or iloprost and or rapid rewarming in a water bath. They don't have any of those 3. They must have good pictures of the injury and perfusion imaging. And the final question, does this patient meet all the criteria for the study? If you select no, you can just use this as a screening tool, but you don't have to, but we'll know that that indicates we won't continue looking at the rest of the information in the survey. for that ID. Any questions?
No, sounds straightforward.
The demographics is really straightforward, so I'm not going to spend a ton of time here. You'll answer the patient's sex at birth, race and ethnicity. You can select all that apply or type in something that isn't on the list. We're interested in this somewhat small list of comorbidities. There could be more, but we're just going to ask for this information. Does your patient have frostbite history? If yes, more questions will come up. Did that injury result in an amputation? And the date of the previous frostbite incident, if known. Or you can guess, if you can guess the month and the year or just the winter that it was, that's helpful. Mental health history, we have a small list here as well. We are interested in housing insecurity. We have some different definitions for housing insecurity and homelessness. And then we're interested in the home security type, unhoused and unstable, and then transitory is a mix of unhoused and unstable. And then we're interested in this because we think that it's likely that homelessness can have an effect on the outcomes of severe frostbite patients. Alcohol abuse and dependence. Illicit drug use defined by your local practice. Tobacco use. Insurance. Amputation history. I've only seen this one come up a couple times this past winter. So if you have a patient that had a previous frostbite amputation or say from a diabetes complication amputation, we need to see that here so that we know how whole their hands and feet were when they came in before their injury. So you can fill out a surgeon sheet here indicating what has already been amputated before they started this admission for frostbite. And then you can select the hand that was amputated previous to this admission, and then you can click on these guys here to indicate what was amputated. I'm back in the Redcap survey. And here's your clickable hand. I'm going to say my patient had just part of his finger amputated a couple years ago. And that's it for that one. Any questions?
Nope.
No.
Injury. Let's see, this survey is looking at, want to know if your patient was transferred. If yes, the date and time. If they came right to you, what time were they admitted to you? And the injury onset. And this is where we allow your best estimation here. Can't be more than 24 hours or they don't qualify to be included. Was rewarming done prior to seeking medical care? If yes, the date and time. You can estimate on that as well. And then this question is getting at rapid rewarming, specifically looking at a circulating warm water bath. And if that was done at your site, the time and date, a large window of estimating when rapid rewarming was done. Select the part of the body that rapid rewarming was done. And then we're looking for additional warming methods. If it's not on the list, you can type something in the box here too. What factors were present at the time of frostbite injury? You can choose all that apply, or type something in the box if we haven't thought of it yet. If trauma is selected, this question will pop up. We'd like you to select what type of trauma. And you can type something in if we don't have it there. Was hypothermia present on admission? If there are other traumatic injuries documented, you can select all that apply here. And was the patient on any of these medications at the time of injury? We're interested in anticoagulant medications and antiplatelets. We have a list of common drug names here. That is it for that one. Do you guys do Doppler assessment on your frostbite patients?
Yes. We do.
So this one, let's see, let me pull it up on the Redcap. So you would select or type in the time, date and time the assessment was done, which extremity, and then select if each digit was a pulse present, absent, or not documented.
Okay. And is that, I mean, we don't do it just once typically. That's for the first assessment. Is this before treatment? Oh, initial treatment. Okay.
Yeah. Yeah, initial treatment. Actually, the vast we've kept this. Lucy Wibbenmeyer's, the University of Iowa, does a ton of Doppler, and they use those really small probes, so they can get down to the tips of fingers and toes. Well, not toes is a little iffy, but most centers don't beyond normal pulses, larger pulses. So we've kept this in. If you guys use it though, it'd be great because we don't have a ton of data on this, and this is kind of a low tech way that the military would be very interested in assessing for severity of injury, because it's hard to field deploy anything that needs a lot of tech or gear, or, so
Okay,
great.
good.
Survey 5 is looking at the initial clinical assessment. This is the visual assessment where you're going to share de-identified photographs with us. We'd like these photographs within 24 hours of admission. If you have some questions on the soonest photos available and what you have, feel free to reach out to us. So then this one, it'd be like the clickable hand in the other survey I showed you. You will select the type of the body, part of the body that has the injury, and then you click on the little hand or feet. So within the first 24 hours, I looked at a photo and talked to my PI, and he said, yes, that part is definitely grade 3 frostbite. And then you can upload a photo of the top and bottom of the foot or top and bottom of the hand. If there's more areas that have extreme severe frostbite, you can select on the limbs here too.
So through this, it'll auto calculate the Hennepin frostbite score, which you guys can either save, or my plan is to download your guys's data for you and send it back to you. So if you want data on your site specific stuff with all these extra calculations and things that we're doing on the back end, you'll have access to that data also.
Oh, nice.
Yeah.
And then I'm going to jump to 7 real quick. It's exactly the same as the one I just showed you, but we're interested in how the frostbite looks 24 to 72 hours later, because the presentation can look more impressive after the first day or so. So it might change on the severity that you see of how deep and how far the frostbite goes. And there's another place to upload photos there. And if your photos are past the 72-hour window, please reach out to us. This is not a hard line. We'd still be interested in seeing how it progresses. And then you'll have the frostbite score here too.
Okay,
And then
so
it's going to be a similar assessment for blisters. So if there were blisters within the first 24 hours, this is where you could enter that information, either looking at the photographs or talking to the PI or the burn surgeons, and then selecting which digit is affected with blisters. There's a spot for hemorrhagic blisters and serous blisters. And then you'll do the exact same thing in 8. And we didn't update that one yet to the grid. It's on its way. But that would be just selecting, looking at the blisters within 24 to 72 hours.
okay.
9, we're looking at the formal perfusion assessment. So if one type of imaging is used prior to treatment and another post-treatment, select both. So you can select Luna, micro, and bone scan if necessary. If you have more images taken during treatment, submit the prior to treatment at the start of the treatment and then the end of treatment or immediately following treatment.
Do you guys do any post treatment in angio or ICG, SPY, or bone
Usually
scan?
the SPY, the ICG.
Okay. What day do you do it immediately after, or do you wait?
Usually immediately after, and then
Okay.
then sometimes the next day again, just
Oh,
if it's
nice.
not improved.
Yeah,
Usually quite
yeah,
a bit.
yeah. That's great.
Select all the perfusion assessments used, and this will create additional questions down below depending on what you select. So if you selected angiography, you could enter the date and time of that scan. Copy and paste the radiology reading, de-identified. And you can work with your PI or surgeons to select the best representable image of the perfusion imaging and upload that here. We don't need big files. Screenshots are fine if you guys are allowed to do that.
Yeah, we would prefer just the screenshot of it. Please don't use your cell phone though to take a picture of the screen. That gets
Okay.
real blurry. But
Yeah, I
screenshots
don't-
are fine, or downloading the flat, composite or SPY file. They don't use angiography, they use microangiography or SPY, so that's a lower
Okay.
down question.
Lower down, same
There it is.
questions.
Microangiography, Luna, SPY, same information. And we know
And then
usually most of the time those don't have a radiology read on them, and we get that just whatever the read was is fine. So whoever the provider was that did the exam in their note, that's fine. We're rereading them centrally, all the imaging,
Oh,
and doing formal Hennepin score assessments with 2 dedicated radiology team. So,
And if there's a second SPY scan, you can enter that in this option here.
okay.
And that is it for the perfusion assessments. Treatment, we'd like to know if they received thrombolytics. If they didn't, this question will come up here asking about if they didn't get thrombolytics due to contraindications on this list. If they did get thrombolytics, we will ask for date and time of administration. Was it IV or IA? If it was IA, this question will pop up asking where it was directed. If it was IA, then we want to know if there was any adjuvant therapies administered at the same time as thrombolytics. Which type what thrombolytic was used. We'd like the total dose. If there is a repeat dose, goes through the same questions. Date and time, route, adjuvant therapies, if that applies, what type it was. And then if you guys get to use Illiprost this winter, you can enter that information here. And if it's available and you're not going to use it, please indicate if it was for a contraindication. If they do receive Illiprost, please enter how many days. And then for each day, we'd like the total dose. The date and time of the first dose and the date and time of the last dose. Sometimes this drug can be used with a mix of inpatient and outpatient, so that information is gathered here. Adjuvant therapy, we're looking at other medications to help treat severe frostbite. And this is those anticoagulant, antiplatelet drugs. And here's a list of common names. Here's the list to pick from. Do you guys do hyperbaric oxygen therapy?
Sometimes.
You can enter that information here. We're interested in how many dives. If your patient had non-weight bearing movement restriction, you can enter that information here. We'd like to know the number of days they were restricted. Same with splinting. If your patient had a splint, where was it and how long did they have it? And topical dressings used during treatment. What do you guys usually use?
Usually use Silbadine or Polysporin.
And was daily cleaning done?
It's really hard to get it out if you don't preparate.
All right, the hospital course, you can enter the discharge date here. And if how many days they were in the ICU.
Oh, sorry,
there
the
any
ICU, does that mean ICU status or they're just in the burn unit on a low status?
ICU status.
ICU status, right? Okay.
Yeah, because we know most units are mixed.
Yeah.
Were there any complications during the hospital stay? If no, then that concludes this survey. If yes, we'll ask some more questions. What was the complication type? We have a long list to pick from. Based on what's selected above, there might be some follow-up questions about identifying when it was first identified for bleeding, stroke, compartment syndrome, pseudoaneurysm, and MI. If bleeding is selected, there'll be a couple more questions about bleeding. Where was the location? Was blood given? And the date and time blood was given. If there was treatment complications, was it due to lytics or Illiprost or an adjuvant med? And if there was complications, was treatment stopped specifically because of these medications?
And that's all in the opinion of PI study. So just when you look at the review.
Yeah, I didn't see too many complications from last winter either.
No, it's fairly rare because everybody screens pretty well.
Yeah.
So
And then the final question, if there were any complications due to adjuvant therapies, you have a list here to select. Discharge, where did they go after their primary stay? If they went from admission to your unit and then psychiatric care, you can enter that number here. I know at our place, we try to get people in psychiatric care once they're done with the ICU so that they can receive good wound care along with mental health care. If they were in the psychiatric ward, where did they go after that? Were they able to return to work or school? Functional assessment, do they need any devices or do they need assistance in daily life? And then ambulation, do they need any devices to get around? At discharge, were they on any of these medications? Just a couple follow-up questions for aspirin duration and DOAC duration and enoxaparin. And the last one. So did the patient have an amputation or undergo operative treatment during the primary hospitalization? So it could be an amputation, a surgical debridement, skin flaps, skin grafting. If yes, then we'd like to know how many times did they go back to the OR? And then fill out a surgeon sheet for that, the picture of the hands and feet, and show what procedures were done. And it gives you options for either the palmar plantar side and dorsal posterior, and then the same with the pictures of the body, dorsal and anterior. And then were those surgical decisions based on any of these conditions here? And blister management during the hospital stay, were they debrided, drained, left intact? We'd like to know the date when clear blisters were debrided and hemorrhagic blisters. The date when clear blisters were drained and the date where hemorrhagic blisters were drained. Will an amputation be required in the future? This is something to discuss with the PI. And if they do have an amputation planned, you can select that here. And we'd like to know if any perfusion imaging was used to help with this plan. If you already know when they're coming back for this surgery, please enter that here. And then you can enter another surgeon sheet that describes the future plan. And then here's where you can show where the amputations were performed during their stay. During their primary stay, you can select one of these, and then you'll get another clickable diagram of the hands and feet, or you can show what was done at your hospital for amputation. And then there are follow-up surveys that are much, much shorter than this. There's only 3 pages for the follow-up surveys. But but we can wait to look at those until things are actually happening. And then the patients that qualify for follow-up will be ones that actually do come back to you for surgery. If they don't come back to you for surgery, then we don't want any more information about them. Any questions? Well, we only have a couple months until winter starts, at least in Minnesota. It's going to be here before we know it.
Yeah, and Emily or Alba is the other coordinator on the study. I think she's doing some things also. One of them could sit with you on the first patient and really help walk you through and talk you through it. But the expanded protocol is very detailed. We spent a ton of time working on that and various iterations as when anybody had identified something that was an issue, we would add it in. And so we'll be sending out the 2025-26 version right, in the next couple weeks, so that everybody will have that updated, can review it and look it over, because we did make a few changes to the database, but nothing too major. But you've been trained on the new one anyway. So, and this will be saved with highlights, mostly the highlights of the changes for the refresher training for each site. You guys obviously won't need to do that since you're getting trained today. But the other sites, we have annual retraining, which we do. I think we pay $200 to do that. That'll be essentially in the fall of each year afterwards. So as far as reimbursement once everybody on your team has gotten their training completed, you can submit a request for the local IRB and your site training, so we can reimburse you for that time and work. And then for each patient, we ask to wait to pay for the patients until the data has been validated and the central assessments of the patient data have been completed. So that usually happens not until after the end of the frostbite season. So like right now we're working on paying for last winter's frostbite submissions. So.
Will we be getting a copy of the version of the source document that you were showing? So I don't think
Absolutely.
I have that.
Yeah, we're making a few more tweaks because this is year 2, but I'll get it to you as soon as we have it finalized.
Okay, great, thanks.
And then is it going to be you 3 entering data into Redcap? Will there be anyone else helping you?
Yeah, we're waiting for Jenny to finish her city, and then Lakeisha and I will be doing data entry.
Great. Well, thank you. We appreciate your help with this project very much.
Thank you. Dr. Meyer, did you have any questions?
No, I don't really. Well, I guess I do. What about the elderly frost study? I know that's separate from this, but
Yeah, so
I don't think I've heard anything about that lately.
So the extremes of age one is still just a sub study, and so it's non-funded. So you can participate in that. We can send you the IRB information for all of that. It's a simplified version of the database, but I am submitting a National Institute of Aging grant, which will evaluate both injury and functional outcomes in the aging population. And so if that gets funded, it won't be until 2027. So we've got a couple of years before that would be up and going. So if you're interested in submitting data for the sub-study, that's for authorship. There's no budget for that one, but it's another way to contribute. And that'll be two separate groups. One is, we put it all under the same IRB, but one's for the kids and one's for older adults. I tried to include both in the military study, and the military was not interested. They didn't want, they only wanted data on people that could potentially be active duty.
Okay, good, thanks. All right, thanks. Sorry, I'm gonna have to go. My surgery is starting, so.
Yeah.
Thank you.
No,
Appreciate it.
we're
Have a
done.
good day. All
Fortunately,
right.
I got the whole thing.
You got it.
all.
That was it.
Thank you.
All right. Does anybody else have any other questions?
I think I'm good. We just have to work with Jenny to get her city done. And then are you sending us the recording, did you say?
It's going to be on
Yeah.
YouTube, I think.
Okay, yeah, if you send us
Yeah.
the link or whatever, then we can set her up when she's
Sure.
done with her city. And then and you'll be sending the updated version.
Yep.
Yes. Yep. I'll send you that soon. And just reach out if any questions come up as you're looking things over or chatting with Jenny and getting her on board.
And
I
should
think
we
what
reach
the-
out? Who should be our primary contact?
You can reach out to me or Alba. We're co-coordinators on this study. When I email you,
Emily's the primary.
Pardon
So I think some issues that we've had as we come up is mostly picture quality. And so talking to your burn team about, getting some good pictures. Burn centers are actually better than most at taking photos, but it's really, getting good photos that can be de-identified, where you can actually see either both sides of the extremity, or both angles. If they take a shot like looking this way, then you got to make sure you get a shot kind of on this side too. But usually we want to both surfaces, and that's I think the biggest challenge. Everything else is pretty straightforward.
We're usually not present when they're photographing,
Yeah.
but from the photos that I have viewed, they've gotten a lot better with yeah, for sure. Yeah, we're probably going to have to reach out to one of the staff nurses who collects the data on the frostbite. Get her help with like uploading things and where to locate some data, but yeah.
Every year, I mean, because it's seasonal, we feel like we have to do a little bit of retraining and just reminders with the staff of like, hey, remember, you got to document this, this, and this. We have a dot phrase, which is pretty extensive. In our Epic, we're happy to share that information if you guys don't have one.
Yeah, we would love that
I'll
because
send
we
it,
use
yeah.
Epic for sure.
Yep.
That will save us time too.
Yeah, we're modifying it to include iloprost right now, but we can send you the one that includes thrombolytics.
Okay.
So.
Yeah. January seems to be our hot time. I mean, December's have been a little different with global warming, to be honest.
Yeah.
So for January is when we get these vortexes.
Yeah. It's all over the place for us. So it's so highly variable. Each year is a little different. Last year was really weird, where it was all those cycles, warm the cold, and warm the cold. But we still ended up meeting our numbers, so that's good. And we only had 2/3 of the sites up and going. So
okay. Yeah. When we get the occasional college kids who are out partying.
Yeah.
Those are the younger folks that come in too.
Yeah. All right. We'll just keep us posted. Emily will send the expanded protocol and the dot phrase, and you'll start getting some emails from me. I try to send updates and reminders throughout the season. I've for sure fallen off a bit on over the summer, but they'll start back up pretty soon.
Awesome. Thank you so much for your time. Really appreciate you guys.
Thank you.
All right.
Bye.
Have a good day.
Bye.
Bye.